The topic given to me is to talk on the obstetric anesthesia, how we may be able to look ahead, what could happen in India as well as in the global scene. I'm not a fortune teller, I'm not a soothsayer, I'm not an astrologer, but from what I had been practicing for the last 38 years, the trends what is seen around in obstetric practice around the globe, well, we may be able to predict certain things, and this lecture may be taken as a prospective happening which is expected around, and there may be mistakes and I may be excused for that. And pregnancy is one particular aspect which is accepted and honored, and today it has gone beyond a level, and the young bellies started putting the graphics on the abdomen and moving around, showing and exhibiting their pregnant abdomen. And pregnancy is a time to be honored, respected and admired. And if you look at any particular civilization, the growth of that particular civilization or the growth of that particular nation is directly representing how far the female population has advanced in that particular country. Because growth of any race or any tribe or any nation today reflects to a large extent on the growth of that female tribe of that particular population. Against the Christian belief that man looks after the female, I may say it is the reverse. The female looks after the male. Female looks after the societal needs of the male, as well as the mother looks after the baby and the husband. And the obstetric anesthesia. Obstetric anesthesia has come forward, really has come forward. In fact, obstetric anesthesia is a combination of science and art. The science of academics and the art of skillful conduct of procedures. And this specialty or very rapidly growing subspecialty of anesthesia is now specified as a specialty devoted to the peripartum, pain and anesthetic management of women during pregnancy and peripartum. And obstetric anesthesiologist is a team member only, is a team member of the peripartum care team comprising of obstetrician, perinatologists, midwives, neonatologists, labor and delivery nurse, and soon another group of specialists going to be added called obstetric medicine specialists as well as fetal medicine specialists, because these two things are coming up very soon, and probably that also going to happen in the next 5 years' time. People are going to get specialized in the obstetric medicine part. That means physicians going to get further trained in the obstetric medicine as well as the fetal medicine parts, and they are also going to add to this particular team. And if you look back, the birth of obstetric anesthesia into medicine, it is very, very interesting to see that there existed prolonged controversy for nearly 150 years. The growth of medicine is only 250 years old. The first 150 years, nobody was recognizing obstetric anesthesia. And nobody wanted, none of our former physicians, our forefathers in the profession, they never accepted or they never wanted anesthetic drugs to be given for obstetric causes. Because they were thinking or they were arguing, pain is accepted as a protective mechanism, but pain of childbirth is different from pain of surgical process. Because they were telling pain of surgery is to remove a pathological process. Because that particular pain has to be treated with anesthetic drug. But here, the childbirth, it's a physiological process. That physiological process need no treatment. I don't know why this sort of attitude came up. Probably they were so chauvinistic at that particular period of time. I believe so. Anyway, that part has gone. Now in the last 100 years, obstetric anesthesia started developing. In the last 50 years, it has gone to a level which is comparable, that an adequate growth has taken place. And in India, in the last 2.5 decades, I may say in the last 2 decades, probably much growth has taken place. And in India, thanks to Dr. Sunanda Gupta, who was a pioneer in leading this particular idea of floating a unit or a specialty of anesthesia in India, she was having this particular idea and she delivered at Calcutta on 26 December 2005 that we are forming a branch of specialty called Obstetric Anesthesia Society, and that is accepted by the Indian Society of Anesthesiologists and everybody around, and the baby was born on 11th of March 2007 at the airport. I thank all the functionaries who assisted in bringing up this particular specialty, and this specialty is growing very fast. But some captions which are coming up in the news as well as in all the communications coming around from the World Health Organization as well as the civilian forums today is one particular caption: why mothers die. In fact, this has taken everybody by surprise. The increasing morbidity and mortality, especially the increasing mortality, made WHO to comment on this particular thing, and that has been copied and that was being orchestrated by all the other civilian forums. Why mothers die? As an answer, it came: save and secure the mother and the baby. And today, we are trying to save and secure the mother and the baby. And as a provider, we want relief of the mother. We want relief given to the baby, as well as rescue them at the earliest. But what do we want? We want more ombudsmen. We want more people who may be able to deliver good things into the practice. And we are in pursuit of that. Some of the recent advances which has come up in the last 20 years around the globe in the matter of obstetric anesthesia are reduction of comorbid factors, because we all accept today the comorbid factors are the killers, or they are the group of diseases which are increasing the mortality rate, and reduction of comorbid factors, because pregnancy is a physiological situation. Once that physiological situation or that particular time is over, the lady comes back to normalcy. So how we may be able to reduce that particular comorbid situation which is there is one particular object of attention. And again, the fasting protocols are modified, and even we are allowing to eat while in labor, and medication timings are modified to suit the patient, as well as how we may be able to reduce the physiological response of pregnancy through drugs as well as through other interventions. And again, pain relief during labor, how best pain relief could be given, and again, popularization of combined spinal epidural anesthesia technique, which I will be coming in broader aspects later, and the use of low-dose narcotic administration during labor, as well as use of optimal gadgets during labor, as well as during operative obstetrics, and services possible today, and the establishment of birthing units, which is something of a recent addition, which is coming up, as well as opening of maternal ICU units or maternal critical care units. These are the recent advances which are coming up in this particular area. Why mothers die, or why parchment die? In fact, this is something which is opening up all our attention. And the reason is that, are they preventable? To a large extent, these particular deaths are preventable. Some, only very few incidents are the reason which are not preventable by ordinary means. But otherwise, these are all preventable mortality. In fact, absence of antenatal care and non-availability of personal support, as well as domiciliary confinement and affordability of treatment, these are the three areas identified as a reason for increasing MMR. Absence of antenatal care. Well, I am sure even today you are all going to believe antenatal care is not prompt, it's not uniform in India. And this is not with India alone, with all the developing countries everywhere. the antenatal care is not proper or not uniform. It is not available everywhere. Even in India, the hilly areas, the rural areas, semi-rural areas, we are deficient in services like that. The domiciliary confinement. After so much of popularization about availability of obstetric care homes and the treatment modalities available, still say 25 to 30% of confinement goes on in the houses, and that too sometimes not even assisted by a trained ayah or a trained nurse or a trained person. That means domiciliary confined without anybody's assistance goes on. And to some extent, some of our population are not able to afford to any particular treatment. And on the contrary, why parturient cry? Why parturient is sad? Why parturient is unhappy? That's because of, again, the particular attitude kept by those people who are able to treat this particular situation. That means the pain and discomfort while on antenatal period, labor, or post-operative period, that is not being well cared. Probably this particular aspect, if given proper care, we may be able to avoid. So, what are the remedial measures open to us today? The remedial measures open to us to prevent this particular increasing mortality rate is an awareness creation, because we need an awareness creation. And unfortunately, we are not the people who may be able to give that much of care, but we, as an evangelist group on this particular matter, we may be able to do some sort of public teaching. We may be able to have some sort of communications released, say how best or how is the pregnancy period has to be cared and treated if there is a problem arising. And availability of trained nurses as well as members of obstetric care team. This is one area we should focus further on. That means we should train more number of people who are able to treat or who are able to identify, who are able to pick up any particular complicating problems and bring it over to a hospital for proper treatment, as well as encourage the family members for confinement at a hospital and availability of drugs and requirement. To some extent, this particular problem is getting solved because drugs are these days available and other requirements also to some extent is being made available. But the last part, compassion from healthcare workers, this also is not existing that much. Compassion, I don't mean any of us, because obstetric anesthesiologists is the last group of patients who step into this particular team. But compassion is needed from everybody who is concerned with the healthcare problems of pregnancy as well as healthcare problems of a pregnancy. That means those people who are called in to assist a pregnant have to be more compassionate. They should be more liberal. They should be more considerate to fellow citizens, to tell about pregnancy and to tell about what are the proper precautions to be taken and tell and make them believe that treatment is available for every particular option. And if we may be able to popularize on this particular matter, some of the problems will be over very soon. And coming to the maternal mortality rates, well, we all know about the maternal mortality rate. Today, the global scene is that something like 380 is the index to 100,000 live births. According to Center for Disease Control, Atlanta, US, the maternal mortality rate has decreased by 99% by the last century. In the last 100 years, the maternal mortality rate has decreased to 99%. And currently, reported incidence is 12 deaths to 100,000 live births. But in India, for some reason, the MMR is slightly high, and that is getting identified. This is some sort of reporting error with the statistics department as well as the ICMR. There is a reporting error which is being notified now, and in fact is less than what is projected in the Indian literature on this particular matter. But anyway, 90% of the maternal mortality present could be avoided, could be reduced, could be decreased, because a complexity of factors operates in bringing up the MMR. And the developed countries and developed countries, the factors are different. In the developed countries, the factors are from the lifestyle diseases say the lifestyle diseases, which brings in the hypertension, drug addiction, smoking, as well as the increasing age of pregnancy. All these things are responsible, apart from the pre-existing maternal diseases. Whereas when it's coming to the developing countries like us, again the same lifestyle diseases like the obesity, decreasing age of the pregnant, and lack of awareness, and existing diseases like comorbid factors, heart disease. These are all the causes. That means most of these causes, on a very close introspection, we can find out that it could be prevented. Because most of the fact is, its effects could be reduced by proper treatment, proper watching, and proper advice being given, and proper monitoring, which is the one thing we're failing at most of the times. And MMR related anesthesia factors, say, it could be further reduced by use of the proper drugs as well as the proper techniques. And anesthesia and high risk. When we say about the high risk, there are some factors which are always there and we cannot have. That means some factors which are already present in the lady. That means some sort of congenital deformities or some sort of metabolic disease which the lady is having already. That means which they already have. Some other factors which they develop in the course of pregnancy. So in short, the mother with the existing disease may be sometimes injurious to the baby when she is going to become pregnant, as well as the baby, due to some defects in the baby, is going to be injurious to the mother, or both factors, the fetal factors as well as the factors responsible from the mother, are both may sometimes risk to each other and they may be able to produce further risk. That means high risk is a difficult term to define because it could be from the mother or from the fetus or from both. Anyway, some of the factors which are identified are all the metabolic diseases or all the conditions which are acquired like obesity, hypertension, lipidemia, diabetes mellitus, increasing age. These are all the factors which are now established as the high risk factors which are preventable. And when we look at obesity alone, unfortunately I have to tell that females from the northwestern part of India as well as northeastern part of India are more obese compared to the female of the coastal areas, say eastern coast of India or western coast of India. Why this particular geographic discrimination or geographic identification has come up is being analyzed. But anyway, obesity now recognized is mostly in certain populations as well as along certain demographic situations. And obesity as such going to produce medical complications, obstetric complications, as well as it leads to anesthesia complications. That means it is a real case. And obesity is one particular factor which we may be able to easily control. Even if the individual is obese while becoming pregnant, that obesity could be still further reduced along the course of pregnancy, and we may be able to bring out the lady to near normal levels and may be able to help that particular patient or that particular parturient from developing any further complications by our careful advice and treatment. And other factors like, say, heart diseases or pulmonary diseases or say metabolic or endocrine diseases which are existent already there. Well, these diseases are there, but effects or seriousness or the difficulty produced by these particular diseases could be reduced by intervention. And that is again one particular area where we should focus our attention. And the progress where we have come through, in fact certain progress we have achieved, especially in obstetric anesthesia. And this is one thing called, well, we may say, eating while in labor. In fact, there was a time when people were not allowed to eat when the labor has started. Today, at most of the hospitals and most of the departments, there is a policy which was different, or it was not existing 10 years earlier, that most of the people are allowing. Yeah. Sorry for that interruption. Most of the departments are allowing the lady to eat while labor is progressing. They are allowing to have small eats, fruits or protein snacks or cheese or wafers or something of that sort. This was forbidden earlier. Till 10 years back, we had a different thought or a different approach. Even in some of the departments, I am sure, in the collegiate hospitals, the obstetricians are not allowing the lady to eat while labor is progressing. But that particular situation has changed. Unless you declare an emergency section, we are allowing the female to eat in small quantities, not to keep hungry, but to eat. That's being allowed. And this particular policy is a welcome policy by everybody. And the pain of labor. We discussed very well about the pain of labor. Unfortunately, this is one particular area where we need more of thinking and further careful planning takes go. In the last 20 years, what I witnessed all over India is that even though we talk much about the pain of labor and the pain relief during pregnancy, as well as about the epidural pain relief techniques and all, even though we teach this particular technique, there is not that much of dedication with all my colleagues, all my juniors. There is not that much of dedication. Where that lack of dedication has come from us, or say from obstetricians, is a point of further inspection. There is not that much dedication. They all learn about it, but they don't put it into practice. There are only very few areas where epidural pain relief is being offered to the lady in labor. And there are so many reasons being spoken around, because people are not that much interested, or say the money attached is not that great, or say manpower is not that good, or say support team is not that effective. So many reasons are being floated around, but these reasons are absolutely silly. And well, if we want, we may be able to introduce. We may be able to introduce religiously. We want to introduce that with a dedication. We want to have it with a compassion. And we have to have this. Because practitioners, postgraduates and residents are to be taught and told. And this particular liberty has to be given to the lady in labor. And I am sure within another 4 or 5 years' time, some sort of right will come in the legal circles that the pain relief has to be given to a laboring lady. And till that particular factor comes up, well, we will be a bit more reluctant, because we want to while away, we want to get away, we don't want to spend that much of time with a pregnant. Probably one of those reasons which I said earlier may be a reason, but anyway, these are not specific reasons, these are not reasons acceptable to everybody. One thing which I would like to say again, that age-old techniques of pain relief, say giving Enternox cylinder or some sort of drugs or something else, are not in practice. Nobody uses. Everywhere today, people use either an epidural or a patient-controlled epidural or a computer-integrated epidural or some sort of other supplements, and mostly a Neuraxis supplement is given as pain relief. And one thing again I would like to say, that if at all you give a proper technique for the pain relief. And regarding the anesthesia choices for operative obstetrics, all over the world, there is a diminishing trend towards giving general anesthesia. And regional anesthesia is preferred everywhere. And regional anesthesia, most of the time, we go for a single dose subarachnoid block or an epidural or modifications of the epidural. And occasionally we go for the conscious sedation, and that also is coming less and less. But never the age-old technique of giving local infiltration analgesia is not at all. It is not commended, it is absolutely said as illegal these days, because a lady should not be tortured to that extent. But you may ask me, I am sure that if everything is failing, why can't I give infiltration? But even then, if you are confident, you go over to GA, but not. And if GA is contraindicated on some other reasons, well, we may be able to think about that sort of a local infiltration. Otherwise, don't give local infiltration. And again, which was discussed in the last session here only, the giving some other supplements If your spinal is failing or if your epidural is failing, well, we give a second time. A third time is not generally recommended. We may move out to a general anesthesia. But some of the practitioners, to save time, or they think their block has acted partly, they start giving some sort of analgesic supplements, and with a little bit of vociferous effort from us, as well as by the supporting team, well, we allow the obstetrician to operate on, but that also is criminal. Because we should not practice that sort of technique. And again, a practice of operating on a pregnant lady after giving a little bit of diazepam is condemned. Don't practice that, please. Because diazepam or a benzodiazepine is not a painkiller. It's not going to give any sort of pain relief. It's just going to sedate the individual. If going to be given in very good doses, that's going to sedate. But in small doses, it's not going to touch the pregnant even, especially at that particular point of time. So I may rather request you, and I rather plead with you not to give any sort of these analgesic supplements when your epidural or spinal is failing. When it's failing, you go over to GA. If you cannot do GA, okay, think about something else, but not these half techniques. Never use it, please. And what are the postpartum issues coming up? Postpartum issues coming up are many, and this is absolutely common to all the developing countries. The one thing which is rather striking is the early marriage. That means child marriages, and the child, 14 or 15 years old lady getting pregnant, and that before a proper pelvic growth is acquired. Since a proper pelvic growth is not acquired, most of the time the pregnancy ends up in a cephalopelvic disproportion, and it's going to obstruct the labor. There will be no progress in the labor. The labor is going to obstruct. Is going to produce ischemia to the surrounding tissue, sometimes rupture of the surrounding tissue, and in the postpartum period ends up as fistula. And the lady is going to have the misery for the future years. And this is one thing where we may be able to do some part of service. Well, we may be able to educate the public. We are the last part of group who may be able to be successful in this particular attempt. What we may be able to promote, we may be able to make people aware in our reach that early marriage is not at all recommended. And it's one, because pregnancy is a honorable time. Pregnancy has to be encouraged only in the later years. Say after the age of 22 or 23, well, one could become pregnant, say before the age of 35. One has to be encouraged to become pregnant, not in the very early ages. And this is one particular area which is absolutely common to all the developing countries. And we are the sufferers. Our public is the sufferers because of that. And as far as obstetric anesthesia is concerned, some of the worst things which is increasing the maternal mortality rate is eclampsia, and that is severe eclampsia or irresistible pre-eclamptic toxemia, or sometimes the heart disease complicated. Here all, today we say a central nerve axis blockade or general anesthesia. These are the best possible anesthetic options. And again, central nerve axis blockade or a single dose subarachnoid block. Any of this particular area could be touched on. Any of this particular area could be practiced. And what are the complications we see in theatre? Most of the time, we end up sometimes seeing maternal hemorrhage, maybe as an axonal hemorrhage or as a postpartum hemorrhage. And sometimes pregnancy-induced hypertension, which is not getting controlled. And eclampsia and preeclampsia, as I told earlier. These are the areas today they look for our support, our care. And I'm sure very soon that is going to be managed by obstetric medicine specialists. And these particular situations could be well managed if you're going to pick up the patient early and going to give proper treatment. And this opens up another area, whether we need a maternal ICU or a maternal critical care unit. The mortality audit data says it is imperative that all the major hospitals where pregnancy-related diseases are being treated should have a maternal ICU unit or a maternal critical care unit. But in a developing country, an isolated or a dedicated maternal critical care unit is not possible all the time. But we can always reserve 3-4 beds with adequate facilities in a general ICU or in a general critical care unit. That means that facility has to be available. It is possible in a large hospital, say in my home hospital at Trivandrum, nearly 800 pregnant patients are admitted every time, and nearly 100 deliveries goes on every particular day. There is a provision for a maternal critical care unit, and they have opened a maternal critical care unit. So many lives we were able to save in the past, and I am sure that sort of facility works out in a major hospital. Say Fernandez Hospital out here, maybe having a critical care unit, but may not be possible in smaller areas. But even in smaller areas, or even in smaller collegiate hospital, we can have an ICU or a maternal critical care unit where, along with other patients, this particular illness also could be treated, or they could be given special provision to treat, and we may be able to have the particular gadgets made available there, as well as a patient trained for that particular purpose. That means excellent and adequate monitoring, as well as prompt treatment intervention could be planned if we have this sort of a unit available. And I am sure in the next 10 years, that is going to be the future development available in this particular scene. And if you go over to the developed world, in fact, they started having the medical emergency team, especially obstetric emergency team, and where even transplanted facilities are available, and they are carrying the patients there, and they are able. But it is not up to us. Probably we may be able to think in that particular direction later. And what are the guidelines which are being accepted these days? The guidelines which were first published in 1998 and republished in 2007, which says that the standard of care being given should be similar in all sorts of obstetric care needs also, and a proper examination and proper inspection of the patient, as well as fasting guidelines, aspiration prevention, and medication, and anesthetic care, and the timing of injection, and anesthesia choices available for GA or regional anesthesia, as well as encouragement of neuraxic techniques, and the use of phenylephrine instead of heparin. These are the guidelines which are coming up. And the one thing which is coming up, or which is being recommended these days in the last 5 years, following the Virginia Apgar conference, is that combined spinal epidural, since it has shown some failure rates, it was very closely observed. And we are finding the reason for this particular failures in the combined spinal epidural is that the spinal needle is not protruding enough. So the recommendation today is that minimum 15 millimeters protrusion of the needle has to be there beyond the epidural needle. Otherwise, the drug will not reach the correct pain. And this is one particular advice being given very well, and that's being accepted by all the practitioners. And the fetal surgeries, I don't want to elaborate on this one. This is something novel, but not getting practiced all over the world. In fact, I had a thorough search on this particular matter. The literature says about that there are only 3-4 places in the world where some amount of fetal surgery is going on. And people are elaborating on the fetal surgery, but the success rate is much less, because fetal surgery ends up with termination of the pregnancy, or say it is injurious to both the fetus as well as to the baby. So there is not that much of growth in the fetal surgeries as it was there 10 years earlier. And one development which is coming up is the provision of birthing suits. In some of the major hospitals in India, they have introduced the birthing suits. Birthing suit is a fashionable 2-bedroom accompaniment where the lady could be admitted, and during labor she could be taken to the adjoining room where a labor coat is placed, and labor coat is there, and all other gadgets necessary for a delivery are available there. Even pipeline supply of gases are there. an anesthesia machine could be rolled over to there, and if you had to give anesthesia, we may be able to give anesthesia in the birthing suit. In fact, this is one thing which is coming up. In some of the hospitals in Delhi, Bombay, even in Hyderabad, I believe, it started, and probably in another 10 years' time, most of the major corporate hospitals are going to have this particular facility, and this is a real advancement which is coming up, and this is something which is rather encouraging everybody to go into some sort of a happy reunion during the labor. And the other parts, which I was avoiding, in the event of a cardiac arrest during labor. Well, let this not happen to any one of us. Well, what is recommended by ASA? This is again confirmed by ASA guidelines. That means maternal resuscitation has to be started. It has to be given within 4 minutes. And if this resuscitation needs hysterectomy and delivery of the baby, it has to be accomplished. And if it is a bleeding episode, okay, you have to go with the hysterectomy. But anyway, matter has to be accomplished in 4 to 5 minutes time. That means this is one particular cardinal point regarding the maternal resuscitation. And looking ahead, what we want is, we want clinical excellence, and we want research in the particular techniques. And we should enlarge the boundaries of care and a compromise-free atmosphere which we should bring up. And probably our outreach goes on. We may have to tell about the services available to all the pregnant, whether they are anywhere in this country. They should be told about, these are the service options available to you, and you have to go out to a hospital. And their treatment has to be monitored and transported to the nearest facility when needed, and make them aware of the situation at any particular time while the labor in progress. And as a society, we may be able to do an annual drill. I request the presidents of AIOA that we should have an annual work plan, annual drill, or annual familiarization techniques. That means every year the practitioners who are interested in this particular area has to be told about what is the best technique and what is the current practice of that particular technique. And some objectives has to be published. Some objectives in very uncertain terms has to be published, which should be kept as a Bible along with you for all practice needs. And for people who need a training, and training in the proper techniques has to be given, and training of minimum 3 months to 6 months should be given to only to trained anesthesiologists, not to anybody else. And major hospitals should start sharing their practical application. They should tell about others how we may be able to circumvent a particular situation, because from their experience they may be able to tell better and better and ensure the availability of manpower, drugs and equipment. In fact, this particular part goes to the exchequer, to the nation, as well as to the country as such in large. But the drill, the objectives, publication and the training, we may be able to accomplish. And these are my thoughts about the future of obstetric anesthesia. And while looking ahead, these are the things which strikes me. And thank you very much for listening to me. And I wish you all good anesthetic skills and better career in your future years. Thank you.